Hi everyone, welcome to our first stream session. Today we hope you enjoyed the opening session and it wet your whistle for what is to come next. This session will focus on HIV. We have a slight change to the program in that Nicoletta Polachek is unable to join us this morning. So we still have two fantastic speakers, Alastair Hudson from HIV Scotland and Chase Ledin from the University of Edinburgh. I'm going to introduce Alastair first, who's going to start off the paper. So there's a slight change in running order as well, just to keep everyone on your toes. Alastair is going to talk about healthcare use amongst people living with HIV in Scotland. Thank you, Alastair.
Hello. Now the fun bit. I've just got to get my slides together. Right, here we go. Hello, good morning. May your whistles be well wetted and be gentle with me. My name is Alastair Hudson. I am the CEO of HIV Scotland, but I also have spent, since 2009, some time across various places I've worked, looking after a community-led research project called the People Living with HIV Stigma Survey UK. And I'm here really to present some of the stuff specifically with regards to Scotland from that data set from 2019, some background and some context. I am a HIV positive gay man, 53 years old. I don't see that as a qualification or an excuse, but it did give context to my engagement with this project, which has been an incredible piece of work to be involved in, and something that I am incredibly proud of. And the people that I've worked with have contributed, not just meaningfully, but significantly. I'm just going to go through where we're at with it. The Stigma Survey UK started in 2019, and the work began before that, and it was a group of organisations that came together globally, UNAIDS, ICW, International Community of Women Living with HIV, the Global Network of People Living with HIV, and the International Planned Parenthood Federation, where I got involved, came together to try and develop an instrument that would capture people's lived experience of HIV stigma and discrimination. And it is my experience that if you want to have a lot of academics go slightly doolally in a room, ask them to define stigma and discrimination. It's a very cruel and amusing sport, and one that I've derived great pleasure from. But for me, as somebody living with HIV stigma has become a bit of an umbrella term for me, that people, I think, are tending to just throw about like a rag doll. And I think we need to maybe be a bit more specific about what we mean when we speak about HIV stigma and discrimination specifically, because we actually do have the tools to consider it and consider it across different settings. And this instrument was an attempt to bring the community together to actually get people living with HIV, the experts, dare I say, with no bias, to actually meaningfully contribute to the development of an instrument and the process of delivering that instrument across various country contexts. It's still ongoing. The instrument was revised globally about 3 years ago by the Population Council and GMP+, and the instrument was reviewed and revised in 2015 in the UK for use across the 4 to 12 nations. So we've delivered it in Northern Ireland, Wales, England and Scotland. I'm going to focus specifically on an overview of the broader data set with some specific Scottish context during my time with you. And the instrument's a beast. I mean, it was a beast of a survey, and we delivered it this time round in 2019 in the NHS and in third sector organisations. It started off with a rollout in the UK in 2009, 2015, and this is the most recent rollout of it. There was an instrument delivered in 2017 that specifically focused on young people between the ages of 15 and 24, which also has a data set. So there's quite a robust amount of information that we do know about people's lived experience of HIV stigma. But moving on to 2019. So in 2019, when we rolled this cantata out for the third time, we managed to secure a sample size of 2,423. The age range is quite broad, but as HIV is getting older, it's now in its 4th decade, 52% of our sample were over the age of 50, a range of ethnicity, and a range of where we captured the data regionally. But interestingly, since delivering this study in 2015, we noticed that there's been quite a shift in the shape of places where people can actually go as HIV positive, HIV diagnosed positive persons. One place that you will go consistently will be an NHS clinic, because we've got great pathways, and once you're engaged in services, retention is good, treatments do work, and people are beneficiaries of that for the most part. So in 2015, our sample was recruited with 50% of the numbers through the NHS clinical settings. In 2019, it was 88%, community organisations, 21%, 7%, and social media, another 20% and 15%. We know that third sector HIV provision and support is increasingly difficult to fund and secure. Scotland still has provision. Many other places in England and in Wales have much more patchy services, so advocates and activists out there, take note. The Scottish sample within that 2,400 plus was 70 persons, small but mighty. So this is a snapshot of what we had. Our sample size was made up of 86% men, glasses required, 13% women, and 1% of persons who identified in another way. And the options were queer, non-binary. And we did actually ask people to identify as trans and define if their gender identity had changed since birth. So we have a very, very small number of people who identify another way, but these are small numbers for Scotland. Ethnicity, I'm not going to read the numbers to you because it's tedious. Age range, as you can see here, again, HIV we know is getting older. I'm 53. It's 40 years on. How's HIV looking in middle age for the community and in particular for Scotland? Antiretroviral treatment, we know that they work. As a tablet swallowing beneficiary of NHS services, 100% of our sample in Scotland were on antiretroviral treatments, and 1% of our sample here identified that they might not be undetectable at this time. Timeson's diagnosis, 79% of sample were over 6 years plus. But moving on, undetectability, the new kid in the block, U equals U, which fits into fast-track targets for UNAIDS and has been taken up basically by most public health and fast-track city agendas, is something that we are all moving towards. I mean, the UK's 90-90-90 targets have been smashed for the most part very, very well. And we're now talking about 95-95-95. So 95% of people who are living with HIV should be tested and engaged in treatment. 95% of them should be able to achieve an undetectable viral load, and as such become undetectable. And it means that infection is, to say the least, negligible within that community. However, we asked people how they came to understand what undetectability means, or where they found out about the concept or the idea of undetectability. Undetectable equals untransmittable or untransmissible in the English. 74% of people heard about this through their doctors and 13% through the nurses, which means 87% of our HIV positive sample, and this is pretty much the same as in England, found out about the idea of U equals U within clinical settings. So that's kind of incredible. In a very, very short piece of time, we've actually changed the sexual health literacy of the HIV diagnosed cohort within clinical services. So NHS, we commend you. Support groups and others and the internet, 5%. But what people actually understood about it is probably even more. So we have the eyesight is not what it used to be. So that is 84% of people are aware that they cannot transmit HIV. Less so, or less likely to transmit, and just as likely as others. But I mean, that's all moving in the right direction. That's a game changer. And years gone by, becoming somebody who needed to start treatment, I'm HIV positive, but I still don't need treatment, was the badge of honor. Nowadays, I'm HIV positive, I'm on treatment, and I'm undetectable is now the badge of honor. So to achieve and maintain an undetectable status is the game changer that we're looking to promote and advocate for, and very successfully deliver within our clinical services at this time. Next up, we have undetectability Scotland versus England, as you can see. Again, the numbers are pretty much the same across England and Scotland, where people found out or became to understand what undetectability means. Again, clinical settings are leading the race here. Support groups or workers, internet and other. And then we get to the new kid on the block, pre-exposure prophylaxis. As a positive person, I employ treatment as prevention to prevent the onward transmission of my HIV. Testing is critical to people's understanding of their status, and we have testing across a range of offers in Scotland, which is quite exciting. Pre-exposure prophylaxis, a treatment that can actually prevent somebody acquiring HIV if they are at enhanced risk or if they deem themselves as being at risk. 90% of this small but mighty sample had heard of PrEP, and we asked them, have any of their partners in last year been on PrEP, and do you feel PrEP has reduced stigma? And the numbers are interesting here. 33% of people, the partners, hadn't been on PrEP. But what's interesting perhaps more is we feel that PrEP has reduced stigma. I mean, as somebody who's living with diagnosed HIV and on treatment as prevention, how does that fit in? So there's a piece of work to be done here around understanding what the diagnosed community can do to support allies in communities that may be PrEP users or indeed have enhanced risk and as such would qualify as PrEP candidates. Experiences due to HIV status. There's still stuff going on. There's a few quotes here because we had free text boxes, but 6% of people said that they had been delayed or refused medical care. 14% of people heard negative comments in relation to their status, and 19% perceived or stated that they had received excessive barrier protection. Sharing status and support. I'm really clear, disclosure is a legal term. I'm much keener to speak about sharing your HIV status or making people aware. And that happens in various aspects of my life. So for example, somebody gets to know I prefer red wine than white. The more they get into my inner wheel, the more likely they are to get to know about my health. But this is quite interesting, making people aware and deeming support within that relationship. Things are moving in a healthy direction. Quite clearly, we can see from these numbers. But again, keeping the eye on the ball is critical. Sharing status and support, England versus Scotland. I couldn't help myself. My Scottishism will behave. But again, I mean, Scotland is again still moving in the right direction with some variances that we need to consider, but things are moving in the right direction. Seeking support. Where are people going for support at this time? HIV support organisations, 29% from the 70 that we have here. Hospital support groups, so the patient forums in Scotland are having an impact. Online support, but 39% of people aren't engaging in support services. Support versus England, just to see where we are here. Slightly more engaging support organisations than in England. Hospital support groups, again, about just under 40% of people are not engaging in these services at the moment. Acknowledgments. This study, like many others, has grown in strength by virtue of the people that have engaged with it. When I first engaged, the project sat with International Planned Parenthood. It moved to FPA, who sadly had to close the doors in 2019. And then East Midlands Sexual Health, NHS Homerton, Public Health England, Hiv Gilead, and various other organisations, including the HIV All-Party Group, HIV and AIDS, amongst others, have been supporters and allies to not just the work, but the dissemination of the work. So, I mean, what we know is that stigma seems to be moving in a direction that is healthy and positive, he says. But there's still work to do, and I think like any health condition that affects marginalised persons or groups that maybe are populations within populations, we need to keep our eye on the ball because the game ain't up yet. Thank you.
Thank you, Alastair. That was a great whirlwind tour of some really fascinating data. And we'll hear from you shortly about some more of it, but I'm going to pass over to Chase Ledin. Chase, if you can pull your slides up, Chase's, I can't remember if I introduced Alastair, but he introduced himself so earlier in the session. So Chase is a PhD student at the University of Edinburgh and gets up to all sorts of things. Do check out his exhibition on HIV history in the exhibition section. So over to you, Chase.
Excellent. Thanks, Ingrid. Okay, so I'm going to talk a little bit today about some of my PhD work in addition to some of the ongoing work that I'm doing for other projects. So my talk today is thinking about the role of post-AIDS or end of HIV health promotion practices in the UK broadly, but specifically in the Scottish context. I'll be thinking about a variety of theories and methods that have kind of emerged, especially since the 2000s and definitely since the 2010s, and think about how we can move forward in the context of Scotland. So let's go ahead. So my overview today is I'm going to think about some of the research aims of my broader kind of project here, some of the theories and methods, some of the key resources that I'm working with, a discussion of some of these images and health promotion practices, and then thinking towards the future. So some of my key research questions are, first, how have end of AIDS or ending HIV health promotion strategies been integrated and or contested in the UK and in Scottish contexts? And my second question is, can critical conversations about ending HIV contribute to HIV literacy strategies? And how might post-AIDS imaginaries help to develop adapted intervention strategies? So it would help to start with a kind of definition of what is post-AIDS, what is ending HIV, what are post-AIDS imaginaries, things that I've kind of been developing in my PhD work, but hope to continue to explore in community projects. So the idea of post-AIDS or the end of HIV is first and foremost about treatment as prevention. So it's figuring out ways to integrate biomedicine within particular populations, encouraging adherence, and finding ways for people to live healthy and promising lifestyles, and thinking towards the future, thinking beyond HIV, thinking about ways in which HIV doesn't dictate the way that they live their lives. But there's also a lot of other kind of scholarship that thinks about HIV and post-AIDS, if you like, as something that is a problem. So Tony Sansett wrote a recent book called Ending AIDS in the Age of Biopharmaceuticals. And one of his claims is that the end of AIDS or ending HIV is a problem unto itself. So in my research, I'm thinking about the end of AIDS and its operation within health promotion as a problem unto itself. It's not simply a kind of self-serving motive. It's not simply about treatment as prevention and access and treatment, but it's something that is problematized, especially as a social concept. It's something that communities are continually struggling with, not simply to access treatments, but also as lifestyle problems or practices. So to that end, I'm thinking about post-AIDS promotion, ending HIV as something that contributes to counter public health. And this is something that Professor Kane Race in Australia has talked about as the cultivation of a viable ethics and models of embodiment that contends not only with the challenges of HIV infection, but also the mass mediation and medical moralization of pleasure and health. So Kane Race's research is very much about the entanglement of how we participate in sex and sexuality, how we develop identities, and how this can be perceived by public health promoters, as well as how that's maybe contested and transformed through health promotion practices. And much of my work is thinking about the kind of tensions that emerge between community members and public health practitioners and why they don't always see eye to eye. And if there's something that we can do to mediate that process and find new ways of presenting and developing health promotion practices. So let's go ahead and have a look at a variety of different examples, both that from the UNAIDS. We'll be thinking about some things from the UK broadly, and then we'll be thinking about the Scottish context. So even though post-AIDS ideas have emerged, especially in the 80s and 1990s, they've taken on an essential role in our understanding of HIV prevention and intervention, especially in the 2010s. So the idea of ending AIDS was really capitalized upon in the early 2010s after the proclamation of TASP was kind of concreted by HIV science. So UNAIDS built this program, which is continuing to be developed, but is kind of leading the way, especially through U=U, in this idea of ending AIDS, especially in the global south. So it's thinking about a variety of medical distribution tasks. It's thinking about different ways of organizing societal norms in order to end AIDS as such. And part of this, as Alastair said in his presentation previously, is this idea of getting these benchmarks or these targets towards getting people to adhere to specific types of treatments, or if they're not using treatment, of using specific types of interventions in order to get these kind of targets towards a future. So especially what's being imagined between these targets, as well as this kind of larger portrait of what end of AIDS might be conceived of as, is this appeal towards a future, either an imagined future or a technical future or a medical future. There are various different types of futures that are being captured by this idea of the end of AIDS. But in health promotion in particular, the end of AIDS is something very much about how do we get to a health state in which people can both participate ethically with the consumption of particular medicines, as well as continue to have critical and often difficult conversations about what that health might entail, even after the HIV is either treated or cured, or it experiences some different configuration within society. So beyond UNAIDS, and more specifically in the UK, we have a lot of different types of campaigns that maybe aren't explicitly end of AIDS, although we'll see after this example that there are many explicit examples of end of AIDS. But we see, especially in the early 2010s, some kind of novel ideas about what it means to end HIV in a kind of societal capacity, as well as a community capacity. So the Terrence Higgins Trust Time to Test campaign, which emerged in the early 2010s, is thinking about this kind of individual responsibility of testing and making sure that you're not part of the problem in society. Of course, lots of people have problematized this idea, but at the same time, this kind of individual participation in a larger project towards ending HIV is the kind of aspiration of TASP. It's the aspiration of a public health ideology or a public health imaginary that already sees kind of the end of HIV as beyond the use of TASP, as something that TASP can control and therefore enable. So let's look more specifically at what this has kind of led into. So the previous campaign has led into a lot of the work that 5016 Street in London does. So they've been thinking about this idea of a Generation Zero, which is not only about kind of the national level, but it's specifically about communities and generations of communities. In the case of Generation Zero campaign, it's about gay and bisexual men, and how they're organizing their subjective experiences of HIV, their historical experiences of HIV, and their personal experiences of HIV. And so in this campaign, which is extrapolated from a variety of other social and cultural media that they're developing, they organize the use of TASP and the use of safer sex promotion around testing, around medication, around PrEP, around PEP, around condom use, in order to suggest that not only is this generation a generation that lived through AIDS crisis, and arguably these characters that appear in these media campaigns actually didn't live through AIDS crisis. They're people who are more recent. They're struggling with new chronic HIV conditions. They are participating in a new generation of ending HIV. So what 5016 Street and what other sexual health clinics are doing is they're saying that there's this population, there's this community that are participating in a kind of task-driven vision of health and health promotion towards a future that might exist without HIV. And so in the Scottish context, we also see this in HIV Scotland's Generation Zero campaign, although a little bit differently, because Generation Zero in the Scottish context is very much more about funding. It's much more about how do we provide TASP and how do we provide treatment for people in Scotland. It's not quite as media-driven as the 5016 Street campaign. Nonetheless, it does contribute to this kind of larger portrait of what's happening in the UK, this kind of idea of there's this generation, these young folk, these people who are in their especially 20s and 30s, who have the capacity to interact with sexual health clinics, to interact with treatment as prevention, in order to make sure that there is no more HIV. So the kind of key takeaway here is that Scotland is only kind of new to this, because this HIV Scotland campaign only came about in 2020, and of course the 5016 Street campaign came out in 2019. So this is very new for the UK. But at the same time, it's already imagining this world or this kind of health landscape in which people, if they contribute to and if they participate in the TASP narrative, they will enable a generation, they'll enable a society in which either there's less HIV, the kind of the demarcation of a smaller community of people living with HIV who are either infectious or maybe uninfectious, But at the same time, there's that kind of aspiration towards a society, an imagined society, of course, where actually people just don't have HIV. So there's this really interesting tension that's being produced by these different media campaigns. So let's do a bit of a discussion, thinking about kind of the key outcomes, thinking about the strengths and limitations of this health promotion practice. So what I've taken away is some of the key ideas about all of these various ending HIV campaigns, both in the UK and elsewhere in the world, are the need for service provision, the need for fundraising and funding generally for TASP and other types of support groups and treatment access. There's community awareness projects, so Hiv Scotland and We Really Care are very much working on these in their kind of design of the end of AIDS and the Generation Zero. And then there's, of course, anti-stigma efforts, which are, of course, entangled with community awareness, but also part of the Generation Zero of saying, we will become informed, we will become literate in what HIV is in order to appeal to a world in which HIV either is less or is no longer existent. So, in my thinking, some of the strengths of these types of health promotion are that it identifies some of the key resources that are needed. And as Alastair suggested, there's quite and indeed, as the introduction suggested today, there's quite a bit of need for continued funding of sexual health resources and reproductive health resources in order to provide that platform for people to end HIV as such. And these things are very targeted. So these health promotion practices situate individual actions in a collective effort to enact global health interventions, which is to say that it doesn't only appeal to individuals as the problem, but it suggests that individuals can participate in a larger social movement towards ending HIV, which perhaps I think it would take more research to suggest that people would necessarily see this as a positive thing, but certainly it could be seen as a positive thing where people say, this allows me to feel like I'm integrated in my community, feel like I'm giving back to the community, and this kind of stuff. And then a final strength here is that it represents the stakeholders. It often shows their faces, it shows them in action. So the Time to Test campaign has portraits of people holding up their fingers. The 50 16th Street campaign has people who live in the London community who are famous actors or they're famous people around who are participating and they're showing themselves as being part of this project to end HIV. And thus it humanizes experiences of HIV for people who are living with HIV and for community members. So there are some limitations in this, and this kind of goes broadly with our understanding of TASP. So it focuses very closely on a technical solution without addressing, and it's very difficult to do this in its entirety, the social determinants such as lack of systemic healthcare, especially in the US context, racial and migration bias in healthcare systems, which a lot of clinicians in London are really thinking about right now and are really concerned about, and then sexual community perceptions. And this is especially where my research kind of intervenes, is thinking about how do we bring community members into the conversations about what does it mean to end HIV? Do community members understand what that means? Do they want to end HIV? I know these are very difficult conversations, but especially talking to community members, they don't always understand what treatment as prevention might enable. And they have different perceptions of what futurity means to them in relation to their sexual health. So what I'm suggesting, and what we'll come back to in just a minute, is that there needs to be more conversations about that. Okay, so one of the other limitations is that this type of health promotion practices prioritizes individual behavioral change over engagement with these communities. So just kind of building upon what I was saying is that it kind of silos the conversation in kind of individual participation in TASP, without having that larger conversation about what would it mean to end HIV in particular communities. And of course, that would lead us on to other conversations about community members talking about STIs, reproductive technologies, other types of behavioral interventions that could be really promising and really help us to understand what people need in the community. So going forward, and this is really a very small sum of the kind of ideas that I'm thinking about, is that we need to problematize the idea of ending HIV discourses, specifically as both Sanset and Race are thinking about a need for discussions about mass mediation and medical moralization practices, which means that especially in the case of the 50 16th Street examples, and especially the UNAIDS examples, what does it mean to idealize a generation of people who is not homogenous, who's definitely heterogeneous? What do they want in this? Do they have any say in how these kind of discourses are being produced? And what do these messages mean for particular populations? So The obvious and glaring problem of these types of ending HIV problems, health promotion practices, especially in the UK, are focused on white cisgender gay men. So what would it mean to adapt these practices to talk about African and migrant populations? What would it mean to talk about young people? What would it mean to talk about heterosexual relationships? These kind of things certainly need to explore these avenues a bit more. What does it mean to intervene in terms of health promotion for ending HIV for these other types of communities? And then there's a further need for community perspectives. So it means that we actually need to go out, need to talk to people. What do they want out of a healthy future? What is a healthy future for them? Can it be captured by health promotion practices, or do we need other types of tools and methods in order to understand how HIV is going to be ended for particular populations? So all this said, this is leading to, or is part of a general project that I'm working for both Glasgow and Edinburgh, in thinking about community workshops for community members to essentially idealize, to imagine, to work through their understandings of what HIV futures might be, what that means in relation to their interactions with healthcare providers. And I'm hoping that these future workshops, which I'll be doing both in Edinburgh and Glasgow, will enable people to kind of think about, to verbalize their understanding of health promotion as both a kind of professional practice as well as a community practice. So I apologize if I was speaking there very quickly, but thank you for listening, and I look forward to any questions you might have.
Thank you so much, Chase. That was great to hear that. I realized at the start of the session I didn't explain what we would do with questions. What I think I'm going to suggest, given we rushed, we've done Alastair and then Chase, is that Alastair, I'm going to pass over to you, and we'll save questions for the end. So if people can put their questions in the chat or in the Q&A box, rather, we'll attend to those questions as they come through the technology. So Alastair, can I hand back to you to present on your second piece on the HIV Stigma Index? Thank you.
My second piece, change of costume. Right, here comes the whole commercial. Every New Chicago, the show opens with a blank stage. Someone walks on and says, I'm going to tell you the truth. Not that the truth really matters, but I'm going to tell you anyway. It premiered in 1975. About 100 years before, Oscar Wilde was heard to say, the truth is rarely pure and never simple. I'd suggest there's a linkage there. Moving on, I'm going to speak to you about positive and negative feelings among people living with HIV in Scotland. Because as a community member, as a tablet swallowing beneficiary of HIV clinical services, and somebody who lives with HIV, and has met many, many people through this piece of work, we have quite a few things that I'd like to share with you about the position piece of HIV stigma. So because these presentations are going to be standalone, I'm going to go through a bit of the initial preamble, so please indulge me. I'll do it quicker this time, honest gov. The People Living with HIV Stigma Survey UK, as I said earlier, began in the UK in 2009, and we've had various versions of it. There was a study that was delivered initially through community organisations because we perceived that NHS ethics was going to be a beast of a task that, as a community research project, we might not be able to kind of climb that hill very easily. It is a beast of a thing to do that I wouldn't wish on a dog. However, we did, and we have 3 times since. So this is an ethically approved NHS study delivered in the NHS with NHS ethics, which we're incredibly proud of. And the team that have gone on the journey, Irene Lotte and various community members, organisations and partners, have been beneficiaries of that journey. And it's kind of informed the national narrative about what HIV stigma means. So whenever I see HIV stigma or HIV stigma and discrimination or raising funds for HIV stigma, I go, tell me where, tell me what, and tell me how. I now require people to be specific. So what we're going to do now is speak specifically about people's feelings around living with diagnosed HIV. So the diagnosed community in treatment, for the most part, are kind of beneficiaries of great services. So this presentation is again going to speak about lived experience within the year previous to when they engaged with the instrument in 2009. So some background to where we're at. 2,423 kind people decided or elected to share a little bit of their soul and their identity with us. Because every time you commit to a research process as a participant, as a punter, somebody living with a health condition, you share a little bit of your identity and your soul. And I require academics to carry that with the greatest of kindness and consideration. I mean, HIV, as we know, has been tested and researched up hill and down dale globally and in the UK. And as an activist and advocate and as a community member, I certainly am very keen that we fight to have that space held in the greatest of integrity. So 2019, 2,423 people took part. Again, the shape of where we recruited changed dramatically since the previous rollout in 2019, in that one thing's for sure, once you are in diagnosed care, one place that you will go without exception will be to your NHS clinical setting to secure the treatment to manage your HIV and hopefully prevent the onward transmission of your diagnosed condition. So between 2015 and 19, we had greater participation from the NHS than we had in community organisations. And we know from 2009 to 2015, over 40% of the organisations that were working in community had simply disappeared. They weren't there. HIV care and support is now being delivered in a range of places. You know, help the aged as we're getting older, organisations that are going to be delivering HIV support, competency building in those places might be something that we need to start considering more and more. Moving on. Scottish participants, again, we're speaking about a small sample size of 70 people, 86% male, 13% female, 1% who defined their gender in another way. We know HIV is getting older, so that's reflected in the ages here, and ethnicity, white, Scottish, other white, Black, British, mixed and others. There is representation there, but for the most part, white, British, white, Irish in the small sample from Scotland. Antiretroviral treatment, the magic that keeps us alive. 100% of the sample we had in Scotland are on antiretroviral treatment, and for the most part have achieved and maintained, it's a live document, an undetectable viral load and undetectable status. Time since diagnosis, again, we've discussed previously. So undetectability, 77% of people believe their understanding of undetectability is positively impacted in their life. You know, and people's understanding of what that means is significant, I think, in relation to how you feel about yourself, your identity, your place in the world, and certainly your ability and competence in terms of how you engage with the medical model. I think HIV has been a game changer in terms of how we relate to health conditions. The systems that supported the Ebola response, the SARS response, and more recently the COVID response stand on the shoulders of giants that worked in the early days of the HIV response. The power balance between medics and patients has changed dramatically. We now actively inquire about treatment options, side effects, and process and progress over treatment and healthcare within engagement. And that has been directly influenced by advocacy and processes and programs and systems and promotion and the systems that we've developed since the beginning of the HIV/AIDS response 40 years ago. We know that 87% of people found out about HIV, U equals U, undetectable equals untransmittable within the NHS. That's incredible. So the NHS is not just a place for caregiving and the provision of care and the provision of medical treatment. It's actually a place where capacity is clearly being built within the diagnosed community and within the PrEP community. So within this, positive feelings in relation to HIV status, of the 70 in Scotland, 89% of people felt they were in control of their health, 77% as good as anyone else, 76% of people positive about the future, and positive about life in general. Versus England, the numbers are not significantly different, some variance, but things are moving in the right direction. And when we look at the sample from 2009 and 2015, the curve of stigma experience or deemed or self confessed stigma experiences and understanding is moving for the most part in a positive direction. However, we still have work to do. 35% of people, which is a third of the sample, still have feelings of shame, guilt, blaming themselves, and 49% of people in Scotland feel that they have low self-esteem, and this is specifically in relation to their HIV diagnosis. Negative feelings, Scotland versus England again. I couldn't help myself, but you know, there's some variance here. For the most part, the numbers in Scotland, with the small numbers we have, are not hugely different to the overarching 2,400 plus sample. There is some variance, interestingly, for Northern Ireland, but for Scotland, the numbers are not hugely different. Worries versus experiences. This was the piece that was interesting. We asked people if they felt they had been gossiped about, verbal abuse, treated differently at social gatherings, treated differently at family gatherings, treated differently in healthcare. And then we asked them if they felt that was specifically in relation to their diagnosed status. And this is what we have here. So there's quite a bit of they think going on. But this gives us a way to really consider where people's lived experience actually lives, rather than what we think they think. I think it's very easy to get into that space with something that's a stigmatized or a taboo condition or a taboo thing. I think we now actually know enough about where this lives for people to start being very, very specific about how we start measuring it, but perhaps more importantly, how we start communicating about it. It is my opinion, not the opinion of the study necessarily, but my opinion that we really need to start revising the lexicon that we're using to describe HIV in this country. We have challenges and still many, many things to do, but the pity party that was certainly is not supported by much of the data that we're seeing. And I think people's experience of it is changing quite dramatically in relation to lived experience. Much to do if someone's living in extreme poverty, the resilience of somebody who's living from a marginalised faith group or from another country and they haven't managed to cope well with their HIV diagnosis and country of origin. Getting people integrated into a UK health system is something we might need to consider. And this is an interesting conversation for this conference, actually. New entrants and migrants. How do we get people with great rights and a constitution that are positive? How can we ensure that that filters down to end users and to service engagement and indeed health-seeking behaviours and practice? Experiences due to HIV status. I'm not going to read these to you because quite frankly I can't see them, but I'm going to read one of them to you about sharing their status. On the whole, this is very positive and liberating. Somebody said to me once when we're doing the initial study that they were clear that if you want something to grow, put it in a nice, moist, dark place and it'll become a scary monster very quickly. I think the idea of disclosing, which is a word I hate, making people aware of intimate aspects of your life is a brave thing to do. And if someone does choose to share something like a health condition with you, or the need for an abortion, or anything related to their identity or their health, it must be guarded carefully because they're sacred things. Sharing HIV status and support. Making people aware of your diagnosis within families. These are people who have made their family aware, or their parents or their friends or their partners aware, and the level of support that they receive is incredibly encouraging when you look at it in a bar chart like this. Again, this is not everyone's experience, to be clear, but across the whole study, this is pretty much on a par. We asked people about affecting change, and that what did they feel was the most important thing that we had to do to change the HIV narrative. HIV education in schools was the front runner, with 84% of the sample in Scotland suggesting that was the most important thing for them. Raising awareness and knowledge of the public about HIV, influencing and advocating for evidence-based media coverage of HIV. I live with HIV. I have absolutely no intentions of dying from AIDS. In England, the third most common answer was providing people living with HIV with emotional, physical, and referral support. So some difference there. But what we know from the work that we've done is that stigma is changing shape. It's not some, monster that lives in some off-planet place. We actually can start having meaningful, considered, and measured conversations about what we mean. So I would like to challenge the academics and partners that when we do start speaking about HIV stigma, we do it with focus and specificity, not a generalized wash. So the thanks on this, I'd like to thank everybody who chose to give us a wee bit of their soul by filling in a questionnaire and taking the time to do this, because it's a very sacred thing as far as I'm concerned, and to our partners across all the participating NHS clinics and cross-sector community organisations currently engaged in delivering support services and programmes specifically for people living with, vulnerable to, or engaged in HIV services. Thank you.
Thanks, Alastair. That was great. I think to hear a lot more about that data, and I think it sits quite well with your first presentation and with Chase's presentation. I'd like to open the floor up to questions. I realise that as chair, I failed in my first attempt to remind people that we are here in a spirit of active listening and discussion and respectful debate. So I have done that. I've just reminded you of that. So we have a number of questions that have been asked already. I'd like to flag up, and my sexy assistant who is working behind the scenes is going to put these forward. So I think one of the questions are from is Kathleen Charters, and I'd like to wonder if people would like to come to stage to ask this, or if they're happy for me just to read out your questions. I'm completely happy to do either. We have the time and the space to invite you as part of the discussion.
I think we've got to basically go back to ground zero and think. And it gives us an opportunity, I think, to actually go, what do these messages be?
I agree.
And how can we make them fit for purpose? In some ways, they've been in the fridge for a while.
Yeah, I really agree. And thank you very much for answering the question. And I'm really enjoying it. I'm just dropping in now as can. So thanks for everybody. And it'll be great to get slides. And particularly thanks to Chase. I really enjoyed that presentation. But everyone's been great. So look forward to receiving the slides. Thanks very much. Thanks for answering.
Thanks, Kathleen. That's great.
See you soon.
I'm going to move over to another question from Jimmy. What did I say? Leslie, who's asked. I mean, I don't know if Leslie, if you're still here, if you want to join the stage, you're completely welcome to do that. I don't know how I ask you that. Sorry, this is not as seamless as we can. I'll read your question, but Leslie, you can feel free to join the stage, and maybe Jimmy, you can ask her. Leslie's asked, does the question regarding a undetectable meaning cannot transmit HIV refer to sexual transmission only? Does this question explore knowledge about non-sexual transmission, such as sharing injecting equipment? A really important question from Leslie. Alastair, again, I think this is to you.
I think there's a couple of pieces to this, Leslie, but thank you for the question. I think the whole thing about, we live in a country that for the most part has a culture or a thing that where we are a country of, for the most part, sexual transmission, in that HIV is transmitted for the most part through vaginal or anal sex. And I think when we speak about HIV transmission, I'm really, really clear. For HIV to be transmitted with increasingly less numbers at population level, we need to start thinking, for HIV to be transmitted, it has to be present. And it has to be present untreated and undiagnosed. And increasingly, by getting people into testing, treatment and care, for example, if you're diagnosed today, you will leave the clinic with treatment, and you could potentially achieve, all being well, an undetectable status within 4 weeks, which is great. So injecting drug use is an issue that I think in some ways needs to be considered in terms of transmission and HIV acquisition. But I think for me, the question was in relation to HIV transmission. The specificity within that is a more complicated question, but the question was crafted with a view to people's understanding of how HIV was acquired or transmitted. I don't speak about passing on, getting, or catching, because I think HIV, for the most part, is transmitted through people not being aware that they have an HIV status that's undiagnosed and untreated. Otherwise, it's about coercion, rape, or abuse.
Can you speak in a way to the work that these campaigns are doing to include different communities or different populations, or in terms of in light of the conversation that we've just had? Is that something you can speak to?
Yeah, absolutely. I mean, there are obvious limitations to these different types of health promotion practices. I guess we could look at Terrence Higgins Trust's variety of and historical evolution of their health promotion practices. So a lot of the work that they were doing, especially with It Starts With Me campaign, is very that kind of individual centric. Isn't just white cisgender gay men. There are a variety of different people who are being represented in that campaign. It is still a kind of evolving campaign. It's been happening. It happens each year. I mean, it takes on a new form. But THT has taken on a variety of different types of health promotion campaigns since then. So the more recent one is them working with people who are HIV positive or newly HIV positive and talking about their occupations. They're talking about what they do in life. So kind of not necessarily illuminating people who are HIV negative and want to maintain the HIV negativity, but also talking to HIV positive people and kind of creating a positive effect and deracinating stigma by giving a face to people living with HIV and stopping HIV transmission. Going back to the limitations of that and speaking to the conversation that you're having here is that all of these conversations are usually about sexual transmission. So they're not very much about injecting substance users. They're not about, I know that there isn't a lot of vertical transmission, but there's not conversations about that in terms of ending HIV. There aren't really conversations about migration and ending HIV in the UK. So these are certainly pathways that we need to be thinking about, even if it's not about the kind of visual cultures of ending HIV and having these conversations. We actually need to have community participation in creating conversations about that kind of stuff. So what does it mean to end HIV for people who are injecting substance users? And does that mean something in the context of Glasgow? Does that mean something in the context of Manchester or London? And does that maybe change how we should be talking about the end of HIV, if we should be talking about the end of HIV?
I don't know whether we should be. I'll tell you why. I think, with the end of HIV will become a health condition that we have the resources to manage and or treat and or cure, like malaria, like TB, like diabetes. I think it'll move into a space whereby we will have structures and systems that can actually enable, hopefully if the NHS manages to retain and survive, systems that can actually support health-seeking behaviours and conditions. I think perhaps the language of ending AIDS might not be the most useful, because it's that you're looking at an end point. As I said earlier, this mug, life is a journey, not a destination. It's now had 5 tea bags in it, so it's not looking too pretty. A bit like the industry that grew up in sexual health promotion prevention in rapid response to the needs of the HIV/AIDS crisis, as was that's now our HIV response. So for me, the thing that's really particular in this space is the branding of sexual health. I think the thing that's exciting for Scotland is this one campaign for Scotland is quite an exciting way to go. We know test, get to know your status, health-seeking behaviours, the promotion of that is critical to people living well. That underpinned by resilience. I noticed a question from Drake about the impact of geographical isolation regarding stigma. If you're living in isolation in a rural community in extreme poverty, it's very, very different to living in rurality and from a lens of wealth or happy, high-functioning relationship. Or great access to a system or structure near you to support your health condition, whatever it is. So I think resilience is the kind of thing we need to be looking at population level. Digital access, if we're going to go to digital campaigns, for how that's going to look. But for me, we did, in the 2009 launch of the Stigma survey, a rather mad wee thing with Annie Lennox at the House of Commons, lovely woman, and good fun. And we branded that as Give Stigma the Index Finger in 2009. So this was the brand for the people living with HIV Stigma survey that the team we had came up with. So, that moves into different spaces. So basically, everything all just new again. It's just the messaging and the campaigning. We're basically looking at how do we ensure resilience underpins health-seeking behaviours, awareness. I think as a platform, it needs to be a table with 4 legs, if you like. awareness, access, advocacy, and understanding. And then obviously the rights, and then the stigmatizing piece, minimizing that to the greatest extent we possibly can to ensure people can engage well.
We have time, and I know there are 40 people in this session. So if anyone wants to ask any further questions or make any comments, please do say. We have time. I also don't want to keep you away from your turkey sandwiches. So we also don't have to stick around. But I think this has been a really rich session. I think the kind of presentation of the stigma index data alongside looking at the campaigns that are meant to speak to or with these communities is really interesting, and where they perhaps speak across each other, or especially in terms of what it is that our shared goal might be, and how that's can be conflated. Are there, so I'm going to open it up to the audience again one more time if you had any questions, or if if Chase or Alastair, you had any final comments you wanted to say before we bring the session to a slightly early close. Any comments from the two illustrious speakers?
Illustrious.
No? Okay. Okay, then thank you, folks. I think this has been a really good session. We did have one speaker down, so we probably have nicely come in under time, which makes it a nice, relaxed conversation. We will release a poll, an exit poll. We got it wrong at the start of the conference, so we're going to do that now. Oh, right. Question from Joe, or comment from Joe about the evidence for and wider application of UE equals U in non-sexual circumstances. I think this is a really important question. Joe, I don't know if we want to kind of discuss that. I think it was discussed earlier to an extent. I think yeah, I think that was discussed earlier. If folks had something else to say that they wanted to add to it. Right, just seeking the evidence. Sorry, I'm having a conversation as while chairing with the chat box. This is what you shouldn't do when you chair a session. So thanks, everyone. And Kathleen, thank you for your comments about gathering knowledge and learning. I'm going to, Jimmy has, I think, or Deeksha has released the poll. So please do fill out the poll before you leave the session. Thank you, everyone, for your presentations and your time. And we look forward to seeing you at the rest of the conference. Don't forget the mindfulness session that takes place during lunchtime, and do have a look at our exhibitions and the poster stalls before you come to our session at 2 o'clock. So thanks very much, everyone, and see you around the session soon. Thank you.